Okay. Questions? No. Okay. Small intestine. You know, small intestine has number one about 3 parts. So duodenum, and then jejunum or jejunum, and then ileum. Okay, duodenum has 3 parts: first, second, third, and fourth. First and second part is peritoneal, third and fourth is retroperitoneal for duodenum. It goes backwards across the membrane and it's retroperitoneal. Third and fourth part of duodenum. So if I were to draw duodenum, it's a C shape like this, right? So that's where the head of the pancreas will be, in the C-shaped areas. The horizontal part on top, the top horizontal part is in green, is part 1. The vertical part, which is yellow, is part 2. And then the bottom horizontal part is 3. And in the end, where it loops the pink area, is part 4. That's duodenum. So anyways, it's duodenum first, then jejunum, and then ileum.
3 and 4 are retroperitoneal?
Yeah. Okay. For duodenum, third and fourth part is retroperitoneal. Okay. Now, of course, when you talk about duodenum, you know the organs related to it. Medial in the C-shaped area is the head of pancreas, bless you, and me. How about the rest of them? Yeah, let's do the rest of them. My child, you bless. Yeah, it is recorded. Those are fake blessing when they say my child. You know, give me some money, then I'll bless you. That's what they say. It's waiter tips hand, but upside down, pronated, right? You supinate it, it's much better. So when they say my child bless me, meaning give me money undercover, not like this. Yeah. Okay, so duodenum, medial to this head of the pancreas. Superior to this is what? Liver, excellent. And medial to it is kidney, right? The right side kidney and liver. But now the second part of duodenum, you guys did some questions. We did some questions yesterday. Those of you who were here were here. Those who were not here, you were not here. So in those questions, what's related to the first part of duodenum, posterior to it? Very important.
Gastroduodenal artery.
Gastroduodenal artery.
And the portal triad, except for the artery.
Bile duct.
Portal
Portal
vein.
vein. There you go. 3 things. Excellent. Now the second part duodenum, what's related to it? Ampulla vater, pancreatic duct, head of the pancreas, and superior pancreatic arteries. Superior and inferior pancreatic arteries, the head of the pancreas, right? Good job. Second part of the duodenum is related to, so let's do this quickly. Duodenum. I get bored easily, so I'm like a newborn, you know. You have to entertain me, otherwise I get bored. So you have superior pancreatic duodenal artery, inferior pancreatic duodenal artery, and then you have the bile duct, and then you have the pancreatic duct or ampulla vater. Okay, that's the C-shape of the pancreas, what's related to it. And of course, head of the pancreas in here, and then on top will be, right here, will be the liver. Okay, liver. How about anterior to the first part of the duodenum? What's related? Gallbladder. Very good. Okay, so here is the pancreatic duodenal artery, and then portal vein will go here next to them. All 3 of them will go behind the first part of the duodenum. Okay, so first part of the duodenum is this area. Okay, so know that relationship, because that means if there are gallstones, they can cause erosion and go into the duodenum. If there are gallstones, and then it can lead to duodenal cystic fistula, and stones can drop in there or fall in there. If the stones are in the tip of the head of the what do you call, gallbladder, then most likely they will form a fistula with transverse colon. Okay, so they will form fistula with transverse colon.
Is that part of the problem? Stone
Yeah.
in the intestine?
In the small intestine, yeah. In the large intestine, no.
Why?
In small intestine, because you have ileocecal valve, which is usually closed. If the stone comes, you can have obstruction of intestine and cause megacolon or mega intestine or ileum. It's constipation, distension, pain. If it's in large intestine, it's too large, nothing can obstruct it. Maybe while you're passing it, if it's large stone, but they're not that big, so it wouldn't be a big problem. In duodenum, yeah. In transverse colon, no. Okay. Blood supply, nerve supply, we've discussed it before. It's the same thing as the embryology of duodenum. Okay. So now, know that as we go from here to here, the duodenum epithelium, jejunum epithelium, and ileum epithelium is always the same. It's columnar epithelium. But the number of goblet cells increases as you go towards the ileum. The size and number of goblet cells increase as you go towards the ileum. Okay. Villi, microvilli, especially they increase as you go towards jejunum, and from jejunum to ileum it decreases. Villi and microvilli. Okay. Okay, good enough. The entire duodenum, the entire jejunum, the entire ileum is supplied by only one artery, superior mesenteric, by only one vein, superior mesenteric vein. So makes your life easier. But of course, duodenum only the second part and below that, right? So, but when we talk about jejunum and ileum, yeah, sure. Okay. Now let me tell you some. You know what? Let's include in here colon as well. Colon. The main function of duodenum is digestion, meaning breakdown of food. Digestion, breakdown of food, breakdown of food, breakdown of food. The major function of jejunum is absorption. Absorption. The major function of ileum is fat-soluble vitamin absorption. Now it's more specific. Okay.
Just rebelling vitamins?
Fat-soluble vitamin absorption occurs in the terminal ileum, especially in the terminal ileum. Terminal ileum. So things that are absorbed in the terminal ileum is vitamin A, vitamin B12, vitamin D, vitamin E, vitamin K. Okay, these are the vitamins that are absorbed where? In the terminal ileum only. Maybe we should say intrinsic factor in B12. Let's put it this way, just to be more accurate. So fat-soluble vitamin is A, D, E, and K. And then we talk about B12. Yes, it is absorbed in terminal ileum, but in complex with who? Intrinsic factor, which was produced by the parietal cells in the stomach. Very good, very good.
Also, that's the purpose of intrinsic factor?
Hmm?
Is that the purpose of intrinsic
That's all there is, yeah. Intrinsic factor is supposed to internalize B12. That's what it does. It's supposed to internalize B12. Take it into cells from the lumen of stomach and intestine. Not so much stomach, intestine of course. Okay. Now when it comes to intrinsic factor, please remember it's produced by the parietal cells. I'll slow down, write it down. It's produced by the parietal cells, and then intrinsic factor must be activated by acidity. I mean, by the stomach acids protected in the duodenum. Intrinsic factor is actually activated with the help of less acidity, and then only then it can bind B12. Okay, so intrinsic factor, again, if you have less acidity, intrinsic factor might be activated too early and might not be able to bind B12. So the best location to bind B12 is in the duodenum, and absorption occurs in the terminal ileum. Okay, cool. Now memorize something. Without intrinsic factor, you can only absorb 1% of B12. 99% of B12 depends on who? Intrinsic factor. So if there is lack of intrinsic factor, you can give high dosage of B12. You will still have some absorption. Okay, there will be still some absorption. Okay. The major purpose of colon or large intestine is, of course, now let's talk about cecum, ascending colon. Cecum and ascending colon, or just in general, ascending colon. Water absorption. Water, sodium, chloride, potassium. These are the major ones. Their reabsorption occurs primarily where? In large intestine. But sigmoid colon and descending colon we're not going to talk about in terms of absorption, just for storage. Primary absorption occurs where? Ascending and some transverse. So okay, so alright, very good. Now, duodenum. Well, who's presenting that thing today? You? Okay, you should care.
See, he says when he doesn't care when he knows it. He just, yeah.
Okay, so after this you will do it. So in duodenum, absorption occurs. There is absorption. The primary absorption is, in this case, it is absorption of divalent cations. Okay, divalent cations. Okay, duodenum. In jejunum is the primary site of absorption of amino acids, monosaccharides, and lipids. So what are divalent cations? Magnesium, zinc, copper, iron, and calcium. Okay, all of them should have, roughly speaking, +2 charge, although iron can exist in 3 as well. But okay, so the divalent cation, what's the significance? These guys are slightly more charged. When they're more charged, yeah, so they have specific transporters. So that the divalent cation transporter is primarily found in the duodenum. Can you do it anywhere else? Yes. How much? Not much. Right?
Possible, but not good enough.
Yeah. Not only possible, it does occur. It happens. But it's not significant enough for us to, pay attention to. Okay. Okay. Alright, so no digestion, major site in blue, and then absorption, jejunum, and then fat soluble. Let's include in here also bile salts. Bile salts, bile acids are also reabsorbed, not just absorbed, reabsorbed. Bile salts were secreted where? Yeah, bile salts were secreted in the duodenum. Absorbed, I mean, I would like to use the term reabsorb, because once you secrete something, you take it back. It's not like you got it from your diet. Reabsorbed. Reabsorbed. What's wrong with me? Good, because otherwise you would have seen I was making spelling mistake. Reabsorbed. Okay. Bile is reabsorbed back in the terminal ileum. Some in the intestine too. So the bacteria in the intestine also change, it conjugates it. We'll talk about it. Okay, so here you go. Now bile almost 90% of it should be reabsorbed, or 95%. You don't want to bile salts and bile acid. You don't want to waste it. It's expensive to make. Remember, to make bile acid and bile salts, what do you need? NADPH. Yeah, it's expensive, right? Okay, good. Hopefully you can remember that. So again, the histology of intestine is very similar to gastric. Everything is portal vein. Everything is portal vein. Only lipids are not by portal vein. They bypass what? The blood. They go into lymphatic. Good job. Yep. Yep. Okay. Now, so honestly, when it comes to histology, physiology, anatomy of the intestine, what is there? Not much. So when you want to focus on intestine, you're going to focus on what? Path. Path. You're going to focus on its path. Very important, because the path itself will teach you about histology and physiology. Okay? Histology and physiology in the entire intestine is very similar. Very similar. It's just the number of goblet cells increase, especially in colon, a lot more goblet cells. And guess what? When you guys do look it up tonight again, when I say look it up, remember it's your responsibility. When I put on the exam, don't be surprised. It's like the CT scan I told you, and you guys didn't look it up. You're responsible to look up some stuff. If you have a question, copy and paste that picture and I'll talk about it. Okay? Or Tuesday, Thursday, that's what they're supposed to do. Now, goblet cells usually stains blue. You will see that the intestinal mucosa is pinkish on those slides, and the goblet cells will stain blue, just like your uniform or scrubs. Let's not call it uniform, scrubs. Okay? So goblet cells, what do? They produce mucus. They produce mucus. They're supposed to lubricate intestines so you have no constipation, smooth passage of stool or food or whatever you want, digested food. Okay. Okay. Now, all of you should have. You guys received an email with the physiology notes. Read it. Read it. Okay. So when you read it, you have question, ask me. All right. You're supposed to read those. Okay. What are some diseases of intestine? Okay, let's go with duodenal atresia. Anything else? Anything else? Ulcers? Duodenal ulcers? Yeah. Okay. Anything else? Crohn's. Big disease. Big. Very good. Anything else? Do you have the pages for me?
Crohn's is 67.
67. Which one? 65?
Celiac Crohns 63. Ulcer 61. Acute diarrhea. Atresia 69.
Okay, good. That's good enough. We have no more room. All right. So let's talk about, again, whenever one of the diseases or pathology will focus on basic things. What does atresia mean? You know what duodenal means? Related to the duodenum, area of the duodenum. Atresia means complete blockage. You see, it's not necessarily blockage. It means failure of canalization. You know, if you have a solid rod and you want to make a tube out of it, if you don't form a tube, it's atresia. So you have to have in your mind the appropriate idea. Blockage, something come and block something. This is not that type of blockage. This congenital. That means you didn't form a tunnel or a tube. Okay. So now, during embryological development, this is midgut or foregut, let's say, if it's depending where in the duodenum, right? Remember, duodenum is one of those few organs that is also in the midgut, and half in midgut and half in the foregut. Good. Now, when the gut tube develops, it starts growing epithelium so much, rapidly and so much, that it starts closing off. The whole tube closes. Initially, it was a tube. The foregut was initially a tube, because it was like a like this paper. Thank you, Ahmed, for handing your questions. You'll get credits for it. Okay, so this is flat sheet, and it folds on itself, and it forms a tube. That's what happens with the gut tube. And then what happens? The epithelium within in the smooth muscle will grow so fast that the lumen is obstructed, becomes solid. After that, there should be apoptosis. Once the tube fills up, then through the process of apoptosis, you develop a tube one more time. It was a tube, became solid, and became tubular again. So this process is known as recanalization, making the channel or canal or tube one more time. Okay. Now, duodenal atresia is the failure of recanalization. The failure of recanalization. If I were to do it this way, wow, that leak is small, but no. Okay, now we can do it. Think about it this way. So now, the recanalization will occur like this. I have tools. That's cool. Okay. Okay, go. No, that's not what I want. There was something. I think it's this one, yeah. Slowly, by the process of apoptosis, slowly, very slowly, cellular death will occur, and it will recanalize. Okay. And then it goes bidirectionally, right?
Yep.
So it reaches to one area. Remember, foregut and midgut, usually it's the junction of the two. Now, it fails to go any further. So you recanalize the bottom and the top, both, but now you have this gap, this obstructed area. That's atresia. So atresia is this blue area. This is atresia, because it didn't recanalize. If it happens in duodenum, what would you call it? If it happens in anal canal, anal atresia, and such thing exists. Okay? So it can be anywhere during the intestine. What if it's in the esophagus? Esophageal atresia. Okay? So the entire gut tubes go through this process. In stomach, it's rare, unlikely, unless it's in the antrum or pyloric area. Unless it's there. Okay? Because stomach is more wider and dilated. Yes, sir.
Is it the same thing as annular vinculus?
No. The symptoms will be the same. Yeah. But the path is not the same. Meaning the end result is the same. Both will obstruct what? Duodenum. Okay. So if we have this, now what happens when this baby is fed food? It goes as far as this area. Yeah. There's no more going further. Now, let's say, so there's an issue we have. The duodenal atresia. Okay, go down. No? What happened? What happened? Okay, whatever. So let's say duodenal atresia, in this case the bile duct, if it's empty here, the bile duct, then most likely bile will be here. This vomiting will never have bile in it, so it's non-bilious vomiting. But in most cases, the bile duct is already opened in here. So they will have bilious vomiting. Yeah. Again, you should suspect both. You should have both. In most cases, it's bilious vomiting because the atresia is after the ampulla vater. If atresia is before the ampulla vater, of course it will be non-bilious. After, then it's bilious vomiting. Good? Okay. Now what are we going to do? So in duodenal atresia, number one, it is who's at risk? Down syndrome patient. Down syndrome. Huh? Polyhydramnios, sure. Yeah. Yeah. Okay. So Down syndrome patient. Down syndrome patient. And this is trisomy 21, right? Chromosome 21. Okay. Or any other congenital GI defect puts you at risk of duodenal atresia. If you have esophageal atresia, the risk of duodenal atresia is very high. Okay. All right. So these are something. Now, it's common in male. In this case, boys, because it's congenital. Children are born with it.
So why boys?
Lack of X chromosome, I guess. Yeah, I guess. But as I said, there's no evidence. At least I don't know. Okay. So, in male boys, especially again, it's the same thing as pyloric stenosis, firstborn male, and so forth. The same risk. All GI is more common. GI defect are more common in men or in boys. Okay. So that's one. Next thing. So if somebody has this defect, what are you going to think? What kind of complication would they have? Is this neurological defect? If this anatomical defect? If this mechanical defect? Is this chemical? It is anatomical and obstructive. Yeah. Okay. All right. Good. Now, obviously, there is obstruction to food flow. So when the baby's fed, they wouldn't be able to defecate. So they will be complaining of constipation. Obviously, they're newborn, they wouldn't be. Now, if this food is not going past duodenum, what's going to happen? Throw up. They will be vomiting. Okay. So vomiting. The main thing will be vomiting. When? 24 hours after feeding, 2 weeks, 1 week, 1 month, 3 years, 4 years. When would they vomit? Yeah, within 24 hours. Because this feeding is going nowhere. It's getting nowhere. Okay. So first day. So the baby will have vomiting or regurgitation of digested food, obviously. Okay. First day, within 24 hours, 48 hours. Okay, and the vomiting will be, again, let's just say this, within 24 hours. And also this vomiting is bile stained most of the time, right? Which means bilious vomiting. And this vomiting will also have acid stains on it. Okay, because it's gastric acid. You'll vomit out with it. Okay. That's all there is. What else could you expect besides vomiting? Every deficiency. Everything. Yeah. But they won't reach to the point of malnutrition. You know, this baby is not going to be able to survive for long. How much food can they absorb? It's not going beyond duodenum. It's not even reaching to the area where the pancreatic enzyme can actually digest it and be absorbed in the jejunum and ileum. So, it's a problem, right? So, now, the only complaint, the only way the baby will present is with vomiting within 24 hours. Okay? Now, of course, that's not enough for you to diagnose it. We'll do some tests. Tests will confirm it. But let's go, are there possible complications? Dehydration. Okay? Anything else? Anemia? Huh? Yeah, I mean, malabsorption, failure to thrive, this could be, I mean, again, if they live long enough somehow. Anything else? Lethargy. Okay, so the baby will be lethargic, complaining, fussy, all of those true. Complication, again, complication. More. Distension. 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 They will have abdominal distension. Food is accumulating somewhere, it's going nowhere. So wouldn't the abdomen start protruding? Especially stomach and duodenum. Yeah.
So this is
Huh? If they don't vomit, there will be. Yeah. Yeah. Which they will vomit. So in that case, but meanwhile, what they will have some abdominal distensions. Tiny little, but it's mostly in the duodenum area. Okay? The proximal duodenum will be distended.
Like pyloric stenosis.
But you wouldn't.
Like pyloric stenosis.
No. After pyloric stenosis.
Will it be similar, like the distension?
No, in pyloric stenosis, remember, most distension occurs because of the stomach. If there is any, stomach can expand, so you won't be able to visualize that, right? So when we say in this case the abdominal distension is only visible on CT scan. Okay, not necessarily physically. Okay, this is only on CT scan you can see it. Okay, anything else? Constipation, right? Jaundice. No, they wouldn't have any issue with jaundice. Okay, unless again the ampulla is obstructed, which is rare. You know, in that case you'll have acute pancreatitis as well. They will not be able to, yeah. So. Okay, so that's these patients. They'll be only complaining of vomiting and constipation, or not complaining of, moms will complain about their baby. They will regurgitate after eating right away. So now, what are you going to do? Do barium first. Excellent. What are you going to see on barium? Okay, what's double bubble? That's good. Exactly, you will see double bubble. Remember that term.
But double bubble is if there's no recanalization.
What is double bubble?
Two bubbles.
Why? So each bubble should represent something.
The first bubble
Yes.
is dilation.
Very good, Nina. The two bubbles are, one is stomach and one is duodenum. Okay? So the stomach, remember that. Stomach and duodenum. Look, when a baby feeds, they don't feed much, so the stomach and the duodenum will be smooth. But in this case, you will see stomach distended on CT scan. And then there's the pyloric sphincter, right? And then the duodenum is distended. And here is the stenosis or atresia, and then the rest of the duodenum. Because barium is not going to go past beyond what? Atresia. Here's the atresia. So everything else will appear dark. Everything else will appear dark. So here will be dark, around will be dark, here is dark, so the two areas will glow. Okay, so two, if this is the barium, the film, the image, the radiograph, okay, all these terminologies are correct. Radiograph, film, image, X-ray, barium, they're all the same. And you can see that there will be two bubbles. Okay, so that's why it's called double bubble. Because barium will come and glow in the stomach. You will find it in the stomach, of course. When this baby swallows barium, barium is swallowing. It's a dye that you swallow. So when the baby swallows this dye, stomach will glow because it's there. And it will go beyond pyloric sphincter. Pyloric sphincter will close, and the duodenum, it cannot go beyond a certain part of the duodenum. So that area will dilate. As long as you have barium, that area is going to glow. Done. It's like you have two light bulbs. One here, one here. It will glow. Okay, so barium is what we can see on the radiograph. You cannot see the rest of the tissue. It's a dark background. Barium glows. It's a radioactively labeled dye. Yeah. No, it's not atresia then. Then it's not atresia. Then it's just obstruction or stenosis. Atresia means complete obstruction or failure to form a hole. If it's partial, there will be narrowing or stenosis. That's what it would be called. It wouldn't be called atresia. The term atresia is for complete obstruction. Okay. So you will see double bubble. Yeah, you will see double bubble. Anything else? So on barium, good. Let's do next endoscopy. And what would you say on endoscopy? The endoscope will not go beyond the atresia. Excellent. It will coil in the duodenum. It will coil back in the duodenum. Yeah. It will not go beyond the duodenum. Okay. Very good.
We're more than an endoscopy, right?
Huh?
We don't need any more than an endoscopy.
No. You want the biopsy? It's up to you. You will find normal cells. Just resistance to death. That's all. Now what are you going to do?
Resection with the anesthesia.
How can you... What do you mean by surgery?
The resection,
Why would you want to do that?
How would we
If your endoscope is already there, why don't you just make a hole?
you can make a hole.
Yeah,
It was big.
you can make it bigger. I'm trying to tell you in a simple terms so you can understand. You don't have to necessarily resect the whole thing and do open surgery. You can endoscopic surgery. And it's done. Wouldn't you do that though?
Yeah. Let's make the whole.
What would you do? asking you. Forget the procedures that are available.
Yeah, we just
I'm
make-
asking you. If you have instruments, if you can take biopsy with the endoscope, can't you cut as well?
Yeah.
Just make some connections. Okay. Remember, our idea is that you should be able to think on your own. You should think out of the box. If you can do this, maybe you can do this as well. Okay, so you should be a thinker rather than just memorizing. So endoscopic surgery is the appropriate procedure. So you can actually make a hole in there. Yes.
Dr. Moneer,
Yes, sir.
it's like a membrane preventing the food from going
Mhm.
after,
Mhm.
or it's the serosa and everything is squeezed.
No, it's only the endothelium, the mucosa layer.
Only the endothelium.
Yeah, it's only the
It's
mucosa.
like a membrane.
It's only the mucosa membrane. Remember what I told you. When it comes to canalization, it's only overgrowth of the epithelial mucosal layer. It's the mucosal layer that grows so fast that causes obstruction. And then it has to go through apoptosis. Okay? Yeah.
Would there be any complications afterwards, like from scarring?
Should be okay. I mean, scarring in the sense that if you see in babies, tissue repair is very fast. So they tend not to have these issues. So whenever there is dead cells, they replace very fast. They won't have the time to become scarred. But possibilities are there. But it's successful procedure. Very successful. Okay. Okay, so that's for duodenal atresia. Now again, what are you going to be asked? You will be asked, a baby wasn't able to eat or digest food after the first, second, third feed, and they will vomit it right away. Okay, and the vomiting could be bilious. If it's bilious, it automatically compares it to what? Pyloric stenosis. Pyloric stenosis can never be bilious. Duodenal atresia could be. Most of the time it is. In rare cases, it's not. Okay, so duodenal atresia, you should think about it. Especially if you're given CT scan, it shows double bubble. Especially if you're given the history of Down syndrome. Okay, if you have those histories, done. Don't question it. Go for it. Okay. Annular pancreas presents very similar. Annular pancreas. So be aware of those two. They present similar symptoms. So when I ask questions, you'll have three choices: duodenal atresia, annular pancreas, and pyloric stenosis. Those three will be
How
there.
would you differentiate them? Annular and stenosis don't have bilious.
Annular stenosis. It won't have bilious vomiting?
Annulus and duodenal atresia will have bilious, and pyloric stenosis will not have bilious.
Yeah, I know that.
Now, again, they're possible not to have it too.
Yeah.
So it depends if it's lower or upper. Okay. Usually the pancreatic buds, when they wrap around, it wraps around just the area of ampulla vater. So if it's slightly lower, slightly upper, it will depend.
There's jaundice in the annular pancreas, right?
Not always. Again, I'm telling, it depends if the pancreas wraps around before the ampulla or after, or right at ampulla. If there's obstruction of the ampulla, then we'll have jaundice. But you will see it clearly on CT scan. On CT scan, you will see the duodenum. The duodenum will come like this, nice and smoothly shallow, and there's nothing passing through. An endoscope will help you with that as well. When it's pancreas, when the pancreas wraps around it, it will look slightly rough, not so smooth. Yeah, and it's not complete obstruction too. Okay, in those cases, there will be swelling around the duodenum. There will be necrosis. There will be death of tissue. It's not a normal process. This was normal. It just didn't develop properly. Pancreas is actually obstruct strangulation of duodenum. and that means it can lead to duodenal. In that case, you have to do surgery and resect the section of duodenum that is gone through necrosis and death, because it's not viable. You have to cut it and re-anastomose those two ends, put it back together. Okay. Okay, duodenal ulcers. Although we talked about ulcers, again, I'll just quickly go over it. Duodenal ulcer, the most common location is the first part of duodenum. The area of the duodenum that's closest to the stomach. It makes sense because most acid before it reaches the end of duodenum will be neutralized by Brenner glands, and then of course by who? Bicarbonate from pancreas coming, right? So duodenal ulcers are uncommon in the second part and after that. Very unlikely. Whenever you have duodenal ulcers in the third, fourth part, or jejunum and ileum, you're going to think only one thing. Yeah, Zillinger-Allison syndrome, yeah. Yeah. Okay. Whenever you have ulcers beyond the ampulla vater, after the ampulla vater, it's always gastronoma. Otherwise, you know, pancreatic bicarbonate will neutralize that acid. It will not make it that far. It will be neutralized. So always duodenal ulcers are more common in the first part of duodenum. And it's common sense, you know, like you don't even have to think hard about that. Okay, bicarbonate coming in will neutralize the acid that's coming from stomach. Okay, second thing, H. pylori is 100% involved. H. pylori is 100% involved. The only difference between gastric and duodenal ulcer is duodenal ulcer tends to decrease with food intake. Duodenal ulcer tends to decrease the pain associated with duodenal ulcer. The epigastric pain associated with duodenal ulcer tends to decrease with eating. With gastric ulcer, pains increase with eating. If you get confused, think of duodenal, decrease pain. D, decrease pain. G, greater pain. Gastric ulcer, greater pain. Duodenal, decrease. D, decrease pain with eating. Both have epigastric pain. Everything is the same. There's only two things that are different between gastric and duodenal ulcer, and that is, in gastric ulcer, you have a risk of NSAIDs causing ulcers as well. Duodenal is purely acidic. It's purely caused by acid.
Duodenal is not malignant. Duodenal is not malignant, but turned into cancer compared to gastric.
Yeah. Okay. And H. pylori is 100% involved in duodenal ulcers. Okay. Pain decreases with food. So that means you will have pain most likely when you're hungry, when you don't eat. At night time, when you eat and you sleep, maybe 5 in the morning, you'll have this epigastric boring pain wake you up. With gastric ulcers, pain starts after you eat. Now, it's not immediately, right? About an hour, 45 minutes. But duodenal ulcers, the pain will be maybe 2 to 3 hours after eating, like much longer. Okay? So both are after eating, right? Gastric is slightly earlier after eating, within 30 minutes, 20 minutes. With duodenal, hours after, so a little bit later. Okay, so it depends how the question is, because I think previously I asked one question. I said after eating, the pain increases 2 hours after eating. Everybody picked gastric ulcer. Everybody was wrong. So gastric ulcer tends to increase within 20 minutes, within 30 minutes after eating. Okay, if you eat a lot, immediately. Okay, so whereas duodenal ulcer, when you're actually hungry, so when you eat 3 hours later on after eating, you're hungry again.
That one is most commonly at risk of what? 3 hours. Duodenal ulceration.
Yeah. Okay, that's about it. You're gonna do the same treatment, PAC or CAP. Okay. You will do the same diagnosis. You will do butt and then hat and then biopsy. Okay. If you want to do barium, sure, go ahead and do barium as well. Barium is not so sensitive. Yeah.
Is it CAP or PAC?
Same thing. CAP, C, clarithromycin, A, amoxicillin, P, PPI. PAC, PPI,
Is it marker?
amoxicillin, clarithromycin.
And biopsy?
I like to use CAP because, yeah, same thing. But I prefer azithromycin. So you can, or clarithromycin, right, instead of amoxicillin. Tetracycline is contraindicated in pregnancy.
Fail or you
Okay, I want to hear myself, guys. It's contraindicated in pregnancy. Okay? And as a result, you have to be careful with tetracycline. And it's contraindicated in children. Because why? It will cause yellowing of teeth and bone growth retardation. So tetracycline are not so safe. Whereas macrolides are very safe drugs. There's 3 macrolide. Think of, and if you call them by name, it's azithromycin, clarithromycin, erythromycin. They're ACE drugs. Number 1, they will ACE everything. Think of it that way. So that's the difference, you know. And macrolides are also, in a sense, they have to be. They're used usually for people who are penicillin allergic because they're safer drug. They have no side effects, but they're expensive. Thank you. Okay, any questions? No? Okay. Now, duodenal ulcers, as I said, should be straightforward and easy. Go for that. If you have any question, I'll ask you. We've discussed this before. Crohn's disease. You know, if I want to do Crohn's disease, I might as well put ulcerative colitis. Ulcerative colitis. Okay, ulcerative colitis, which is a disease of large intestine. So, colitis means inflammation of colon. So let's just talk about where are these diseases occurring first. Ulcerative colitis only involves colon. Primarily involves colon. Okay, so I'll put here colon. It's a disease of colon. Specifically, which part of the colon? Yeah, sigmoid colon. Excellent. You're studying. Good for you. Sigmoid colon. Okay. Crohn's disease. It's a disease of entire GI tract. No area is spared. Extremely rarely. Okay. So now, especially which part of the intestine is small intestine? It's a disease of small intestine. It's a disease of small intestine. Okay. It's a disease of small intestine. The most common location, so I'll put intestine, not colon. Intestine, not colon. Specifically terminal ileum. Most common location is terminal ileum. Okay. Now, in reality, Crohn's disease can involve any part of the body. It even becomes systemic, but especially when it comes to GI tract, from oral cavity all the way to anal canal. But of course, when you want to compare to ulcerative colitis, we will understand it that ulcerative colitis only has colon, and Crohn's anything above colon. That's how you're going to think. But it does not mean that colon is normal or vice versa. It's very rare. Okay. Celiac sprue. Think of celiac sprue. So in this case, celiac sprue, closed intestine. Most the disease of jejunum. It's primarily a disease of jejunum, duodenum. Whipple disease, also a disease of jejunum. Now there's something known as tropical sprue. You heard of that? Tropical sprue. Tropical sprue, think of T now. Again, terminal ileum. Okay, again, terminal ileum. So at least based on anatomy, we should be able to identify them. Ulcerative colitis. The name colitis is self-explanatory. Inflammation of colon. Inflammation of colon. Of course, it can involve, but it's a very rare any other part of intestine beside colon. It doesn't mean it doesn't occur. It does, but it's rare. Okay. Overall, we're gonna memorize ulcerative colitis being disease of colon. Within colon, what part of the colon? Sigmoid colon. Okay. Tropical sprue, small intestine disease. Within small intestine, terminal ileum, most likely. Okay. Crohn's disease, the entire intestine, especially small intestine,
Especially terminal.
and then terminal ileum very much the most common cause or area. If you have in your book MCL, that stands for most common location. MCL in the book stands for most common location. Celiac sprue, proximal jejunum. Proximal jejunum. Okay. Whipple's disease, terminal jejunum. Both are disease of jejunum. Okay. Now, so it helps us, you know. So in ulcerative colitis, there is inflammation of colon, right? Now, what kind of inflammation in ulcerative colitis? Ulcerative inflammation. Ulcerative inflammation. There's inflammation superimposed by ulcers. Okay, so the name is self-explanatory. So you will find ulcers where? In colon, specifically sigmoid colon, in rectum. Yeah. Okay. So now, ulcerative colitis and Crohn's disease, them two, I would love to compare. You know what? I have to do this because let's compare these two, and I'll come back to those other ones. Let me do this. I know when Lisa used to be here, she's like, oh, we can't do that. She would get frustrated. She would write on her notes, and I'll switch them around, and she gets frustrated. I think Aisha would get frustrated too with her. Then too, like, we can't do this. I know Rahaf will get frustrated when I write green. My eyes hurt. And these are the two people missing, so I can talk about them, right? So halal. You have to encourage them to come to class and study.
They come to class, you can't talk about
Yeah, I know. Okay. Alright. Ulcerative colitis. Now in ulcerative colitis, there is ulcers. There are ulcers. Where are these ulcers? In colon. The colon is inflamed. It's inflammatory disease. See, Crohn's and ulcerative colitis, they're both known as inflammatory disease of intestine. Intestine. I want to see you guys' face, not your phones. Please, put away your phone. Yeah.
ulcers superimposed on
You should have pen. Oh, one more thing. So, now this is what Tasneem is telling me. That you go there and ask for pen and paper regularly. How could you come unprepared to class? So don't do that, guys. And I'm going to tell her not to even, don't even talk to you, respond to you. So come to class prepared. Come to class prepared. You know, that shows me what? That you don't care. You know, what if she doesn't have pen and paper? None of you are Zainul Abidin who used to write in sand and erase and remember everything. When you reach that level, then don't come. But when you do come, so just listen then. Don't, you know, come prepared. Come prepared. Oh yeah, there were 4 students I noticed yesterday. They were taking their exam on their phones. What did I say in the first day of class? Do you remember? No exam should be taken on the phone. So I think, I don't know if I should give you 0 or let you go this time. But next exam, be careful. Don't do that. So, you know, you have to get a device that's appropriate. Get an iPad or get a whatever, you know, not on the phone. Can't take exams on the phone. Okay. And I feel like, you know, whatever we say, I have to come with iron fist. Whatever I say something, it means nothing. You know, that's disappointing to me. It makes me feel like so bad. Like you guys don't care for what I say. I requested it. I didn't even tell you. I requested multiple times. And we give you 6 months to have electronic device to take your exam. Preferred would be a small tablet. So you can put it in your pocket. You can use it anywhere you want, especially when you go to clinicals. So, I mean, you guys got to do those things. I don't know what to do. Oh yeah, please. So from now on, don't ask him about tuition. Talk to Mazen. Don't ask him about when you want to leave the country or you want to go wherever. You have attendance, so you'll be absent. Talk to them. only talk to me about education, because it gets, I will tell you yes, 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 and I don't even mean it, because I don't even know what you're talking about. This is my focus. So they're responsible, Shukrullah is responsible, Mazen's responsible. So when it comes to those things, if you want to have this, that, talk to them. They have all the details. Okay, so just make it easier for me, because I'll say sometime and then I remember, oh wow, I didn't mean that. Why did I say it? Okay, so they should keep the record of you not being in class, you being absent, you want your grades and whatever. Ask them and talk to them and make appointments, do it the right way. And when we announce something, don't overcrowd Tasneem. All of you guys go and then surround her like, oh, what about this, what about that, what about that. Remember, just give her time, she will tell you. Or document everything, please. Whenever something is serious that you want, keep documented, because if I don't have email record of that, I won't believe you. So whatever you want to do it the right way. Especially now you have your emails. Now the emails, did you guys all activate your emails? Okay. Please do that, because I think they want to send you some important emails and some rules and regulation that you have to sign up at least before the next term. Make sure so that next time we don't have these issues, because we have a lot of issues. My thing is this, I don't know if I'm right or wrong, or what I did is right or wrong. You guys can make your own judgment. Honestly, I love freedom, and I'm telling, this is me. I don't like to impose on anybody anything. I feel like you're all responsible enough, you will do things on your own without somebody calling you, reminding you, and being on your tail. That's how I feel. But it hasn't worked. It hasn't worked. It hasn't worked. So that's why we have to put strict rules, and then you can follow them. So if anything that's not documented, that means it doesn't exist. So do things the right way. And far as attendance, there's, what was the attendance rule verbally? What did I say? 15%. 15%. I'm being generous. I thought I said 10. Anybody who, again, you still have about few days. Those who don't come and you're late, I'm looking over attendance, and I will send the record to you. I'll email it to you, and whoever else, the guardian is on the email, and the grade from this week, the whole grade, where you stand right now. I'm going to do that and send it to everybody, to their personal email, and whoever else, your parents, your mom, whoever else is the guardian, they will see it. If you have question, then you can bring them with you and we'll resolve it. That means you could fail if you're more than 20%, even if you get 100%. And I say that strictly, attendance was actually required day one. Especially yesterday, on Tuesday, Thursdays, attendance are required. Unless I've talked to some people specifically, those are different. When you have job and stuff, and the first day when my contract with you was on day one, when you came like, I have this, I can't do it, that's different. But I'm talking about those who don't have those issues. And whoever wants, like a day off or something, you have to bring me proof that you do whatever. You work, fine. You do this, that's fine. But as I said, so if you fail, I given you notice, I think, in the beginning of this term and before even then. So don't talk to me about it that I didn't tell you. You took it lightly, I didn't take it lightly. And I thought you guys would listen, and I thought, as I said, even on the exam, the CT scans, majority of students got it wrong. Where I had told you, it's not like I didn't tell you. I told you, go over CT scan, go over some slides. If you have question, ask me. So you do have to, the whole purpose of me being here is to guide you. At the end of the day, each one of you have amazing brain. You will find a way to learn this material without me. I can speed up the process. I can point out some things, this is how you should learn it. This is where I come from. But at the end of it, it's your brain. All of you have amazing, beautiful brain. You can memorize, you can learn. So if you don't benefit from what I say, then it's useless coming to class. You have to follow instruction. You have to. I always get frustrated when the result is bad, then it bothers me, and then everything else comes in my mind too. So as I said, you know what I have told you. If you fail, you fail. You fail. I think last term we had 6 students fail, and this term maybe more. So you would have to repeat. And I talked to Mazen, and I talked to two more administrators in Shukrullah and Dr. Masab too. Even though I had said before, if you fail, when you repeat, I will not charge you. Because my goal is how I can get you somewhere. Honestly, that's my purpose. But it's not working. The only way people respond when they lose money. So what I'm going to do is, just to tell you, because I don't want to be like other schools and take advantage that, oh, we're failing you on purpose. If you fail, you will have to repeat the course and you will have to pay. But that money will go in a separate account and that'll be used for scholarship for those students who needs financial help. That's what I'm going to do. So it serves two purposes. Number one, you'll get punished for something that you shouldn't do. Number two, somebody else will benefit from it who cannot afford. Okay, so that's what we're going to do. And that's starting next term. So if you fail this term, and I'm telling you, I had told you already, for next term, if you want to repeat this a year from now, the same course, then you would have to pay for it. The more lenience you give people, the more advantage, or not necessarily, I wouldn't say it in a negative way, they forget. They don't take it seriously. I've been told, students are not afraid of the exams. They're not afraid of missing a class. They're actually rejoicing. It shouldn't be that way. You should not miss a class. You should take it seriously. It's your life, but I'm responsible, so I'm going to do my job. I get headaches, trust me. When a single student, forget a lot of you guys. If a single student is not doing well, it bothers me a lot. So, and you have to be, as I said, you have to be a special students. You are special students, but just realize your potential. Don't just take it easy. Okay. All right. Yeah. So whenever I shave and stuff, I'm like, because I want to forget about things. I'm like, I want to feel good about myself. So. I was happy until I seen the grades yesterday. So. All right. Ulcerative colitis. How much time?
It's 9:00.
Well, let's take a break. It's been too long. Yeah, turn it off.
It's not basic.
like the coffee. Let's move on, guys.
Recording and projector.
What happened to the projector?
It's off. Where's
Oh yeah, Mohammed, can you turn on the projector? He's the one in charge.
ده انت شايف معايا انت عجبني